Hi, I'm Tanya Nicholson. I'm the Associate Dean of Midwifery and Women's Health here at Frontier Nursing University, and we thank you for joining us for tonight's event. I'm going to introduce to you to the speaker tonight, and it's Dr. Sue Stone. She's probably very well known to you. She is a certified nurse midwife, and her primary position for the last 2 decades is as the president of Frontier Nursing University. She has grown the university from a small community-based school of nurse midwifery offering a basic certificate program to 200 students to our current accredited university offering master's and doctoral degrees to nurses with more than 2,000 students enrolled. Dr. Stone also currently serves as the president of the American College of Nurse Midwives, where her agenda includes increasing the midwifery workforce through educational quality and capacity strategies, midwifery advocacy focusing on the maternal morbidity and mortality crisis, and growing the diversity in the healthcare workforce. I'm so pleased to call her my friend, my colleague, a mentor, and inspiration. Thank you, Dr. Stone, for joining us.
Hello, everybody. Welcome to our FNU virtual event. We're celebrating Nurse Midwifery Week this week. We're excited to have you, and we're going to do a focus on collaboration this week. And we all know the importance of collaboration to the success of our practices. And so I'm going to kick off this session with a little discussion about some of the underpinnings of collaboration. And I want to talk a little bit about some of the work that we have done between the American College of Nurse Midwives and the American College of Obstetricians and Gynecologists around collaboration over the last few years. So I hope you enjoy it, and here we go. Okay, so title, Successful Collaboration Between Obstetricians and Midwives. That's our focus for this talk. I wanted to define a few terms as we start this presentation, because we do have a few different types of midwives practicing here in the United States. And of course, at Frontier, we are educating certified nurse midwives. And in fact, certified nurse midwives are the largest population of midwives in the United States. Certified nurse midwives are educated in the 2 disciplines of both midwifery and nursing. And they're educated in graduate programs that are all accredited by the Accreditation Commission for Midwifery Education. All students do graduate with a Master of Science degree. At Frontier, it's a Master of Science in Nursing with a specialty in midwifery. The point here is that all certified nurse midwives do have a graduate degree in order to enter practice. Graduates then must successfully pass the American Midwifery Certification Board exam, which is a national exam, and then they are eligible for licensure in their state. CNMs are licensed in all 50 states. In Kentucky, as an example, they are licensed as APRNs under the Board of Nursing. Some states will have their own Board of Midwifery, which is very nice, but many states we are licensed under the Board of Nursing. In a couple of states, they're even licensed under the Board of Medicine. So it's different for each state where the licensure occurs, but we do know that CNMs are licensed in all 50 states. And we must also meet ongoing requirements from the AMCB in regards to continuing education, and most of us have to do that within our state as well. Okay. Certified midwives is another type of midwife. The major difference is that these midwives do not have nursing as a prerequisite. They do have some other type of healthcare education as prerequisite. They all enter with a bachelor's degree, but this path was created for those people who already have a bachelor's degree, at least. Many, for example, physician's assistants will go in this path, but these are people who already have an education, and it wouldn't make sense to send them back to nursing school to start all over again. So this pathway was created about 20 years ago, and very similar to the CNMs in that they all earn graduate degrees in midwifery. Their education programs are accredited by ACME. They pass the same national exam as CNMs. Right now, we only have 2 programs in the United States, and they currently can obtain licensure in 6 states. But it is an agenda of ACNM to expand the options for this degree or this pathway into midwifery. So currently in the United States, there are about 12,600 CNMs and about 100 CMs. And about 95% of the births that they attend occur in hospitals, 5% in freestanding birthing centers or home births. Now, the reason for this is we do follow the women, and women in the United States, it is our culture and our practice to give birth in hospitals. So it's very important for CNMs to have privileges within hospitals to attend births, as well as their practices that they do in birthing centers and home birth. Just note here, you can see that the number of CNMs and CMs is increasing, and you can see this nice upward trend from 2014 through 2018, and we're very happy to see that because we need more nurse midwives and midwives. I will mention certified professional midwives. These midwives may be educated in an accredited program by obtaining legal recognition from a state or province that is evaluated for educational equivalency, or they may be educated through the portfolio evaluation process, which is not an accredited process. CPM certification consists of 2 steps: the validation of midwifery education, and they also have the NARM written examination, which is a national certification exam. Currently, CPMs are allowed to practice and obtain licensure in 31 states, and there are approximately 1,800 CPMs in the U.S. The majority of births that they attend are in an out-of-hospital setting. I don't know of any CPMs at this time that have hospital privileges. It's possible that there's some out there, but I am not aware of any at this time. The rest of this presentation is going to focus primarily on certified nurse midwives and certified midwives today. So the scope of practice of CNMs and CMs is the same. It encompasses a full range of primary healthcare services for women, right from adolescence all the way beyond menopause. And services include primary care, GYN care, family planning services, preconception care, care during pregnancy, childbirth, and the postpartum period, care of the normal newborn up during the first 28 days of life, and treatment of male partners for sexually transmitted diseases. Midwives provide initial and ongoing comprehensive assessment, diagnosis, and treatment, and we have a major focus on health promotion, disease prevention, and individualized wellness education and counseling. So basically, certified nurse midwives and certified midwives provide independent midwifery care within their scope of practice while fostering consultation, collaborative management, and seamless referral or transfer of care when needed. So we are licensed independent providers, but we do work within the healthcare system, and it is our responsibility to have plans in place for what would happen if our woman that we're caring for became ill, and what's the next step, and where are the referral sources for us. There are many studies that show the effectiveness and safety of midwifery care. Cochrane did 2 reviews, one in 2019 and one in 2013, and the review concluded that most women should be offered midwifery-led continuity models of care, although caution should be exercised when applying this advice to women with substantial medical or obstetric complications. I'm going to talk more about collaborative practice for women who have high-risk situations as well later. The Lancet also published a series of articles about midwifery and the safety and benefits of midwifery. And one of their conclusions was this: provision of accessible quality midwifery services that are responsive to women's needs and wants should be part of the design of the healthcare delivery system and should inform policies related to the composition, development, and distribution of the health workforce in all countries. So our problem, what is our problem that we're trying to deal with? Of course, we want women to have a healthy lifestyle, to be healthy, and to have healthy childbearing experiences. But that's not really what's happening in the United States today. We have a problem with maternal mortality. And we know that the maternal mortality rate has risen dramatically over the last 20 years. We also know that this disproportionately affects women of color, with maternal mortality happening 3 times the rate of white women. And so we have lots of issues involved in this, what are in this, but the conclusion that the CDC, Centers for Disease Control, has made is that half of these deaths are preventable. And that's a huge problem for us. How are we going to create the healthcare system that prevents these deaths? We also are dealing with severe maternal morbidity, not surprising. So these are women who probably are near misses, with over 50,000 of them in the United States in 2014. These are women who are admitted to intensive care units with significant complications and problems during childbirth. So why is this happening? It is multifactorial. We have medical reasons, hemorrhage, gestational hypertension, infection, and cardiovascular conditions. We have public health issues as well. So, there's a lot of efforts being put into improving hospital-based care, doing simulations so that we can respond more quickly to hemorrhage, and to standardize the care to ensure the care is appropriate. These things are needed and necessary, and yet we do have to pay attention to the public health issues. We have issues around obesity, nutrition, smoking, and mental health disorders. Many people don't know that part of the one reason for maternal mortality is suicide. So this is a multiple cause problem. We also know that the cesarean section does contribute to this. The CDC did publish a report recently, actually I think it was in 2015, but they reported that the rates of maternal morbidity were higher for cesarean delivery than for vaginal delivery. And that's no surprise, as it is major abdominal surgery. So collaboration, what happens? Many women and fetuses will develop complications that warrant medical attention to assure safe and healthy outcomes. And therefore, collaboration is critical. However, supporting the normal physiologic processes of labor and birth, even in the presence of such complications, has the potential to enhance the best outcomes for women and for mothers and their infants. And so we know that just because a woman has complications, the best care will come when the midwife and the obstetrician work together to continue to care for the mother-baby dyad, and I will talk about that more in a minute. So let's talk about normal physiologic birth. So this is a focus of midwifery, and it is characterized by spontaneous onset and progression of labor. It includes biological, psychological conditions that promote effective labor. It results in the vaginal birth of the infant and the placenta. It results in physiologic blood loss, optimal newborn transition through skin-to-skin contact, and keeping that mother and baby together during the postpartum period. And of course, supporting early initiation of breastfeeding. So these are key components of normal physiologic birth. And when we're talking about physiologic birth, this is what we're talking about. What are disruptors to normal physiologic birth? Well, when we induce or augment the labor, it can disrupt this. An unsupportive environment with bright lights, cold rooms, lack of privacy, multiple providers, and lack of supportive companions. Time constraints, including those driven by institutional policy rather than by the needs of the woman. Nutritional deprivation, like with restricting food and drink during labor. Opiates, regional anesthesia, and general anesthesia. Episiotomy. Operative vaginal birth, such as vacuum, forceps, or abdominal cesarean birth. Immediate cord clamping. Separation of the mother and infant after the birth, or any situation in which the mother feels threatened or unsupportive. So these are disruptors to normal birth. This does not mean they're not necessary and that they're not needed in some cases. It's just that we do have to understand that these do disrupt the normal process. So how can we take this situation and still align with normal physiologic birth as much as possible? And you see this in the initiatives to have friendly cesarean or supportive cesarean situations, and things can be made better. But we need to know that these are disruptors. Now, I really want to talk a little bit about ACOG and ACNM and how we have been working together on collaboration over the last several years. I was privileged to sit on the committee that developed this statement in January of 2017. So this was a group of midwives and a group of obstetricians, some leaders from ACNM, leaders from ACOG, and we spent a day and a half kind of hammering out and updating the joint statement of practice relations between obstetricians, gynecologists, and certified nurse midwives, certified midwives. And so, I'm sorry, it was January of 2018. And so we worked on this for a day and a half, and then we did some back and forth electronically to settle on this. Many of you may not know that this is one version of a document that was first written way back in the early 1970s. So this collaboration is not new, but this effort was to define the concepts a little bit more clearly. And this is a very good, sometimes the people in your unit or the other providers aren't aware of this document. It can be helpful to even post it. And it's readily available online if you Google it. But here we go. The American College of Obstetricians and Gynecologists and the American College of Nurse-Midwives affirm our shared goal of safe women's health care in the United States through the promotion of evidence-based models provided by obstetricians and gynecologists, certified nurse midwives, and certified midwives. We believe healthcare is most effective when it occurs in a system that facilitates communication across care settings and among clinicians. OBGYNs and certified nurse midwives, certified midwives are experts in their respective fields of practice and are educated, trained, and licensed independent clinicians who collaborate depending on the needs of their patients. The clinicians practice to the full extent of their education, training, experience, and licensure and support team-based care. We together advocate for health policies that ensure access to appropriate levels of care for all women. Quality of care is enhanced by collegial relationships, and these are represented by mutual respect and trust, professional responsibility and accountability, and national uniformity in full practice authority and licensure across all states. We work together to optimize women's health, and we recommend increasing both OBGYNs and midwives, utilizing interprofessional education models ideally to promote collaboration and team-based care. And we provide the highest quality and seamless care. In order to do this, OBGYNs and nurse midwives should have access to a system of care that fosters collaboration among licensed independent providers. So this is a critical statement. It kind of lays out the beliefs of both ACOG and ACNM. It recognizes that we are each independent providers, we are each experts in our field, but that together we can provide the best care. So this is an important document for you to be aware of. And it kind of, in a summary, we have common values between ACOG and ACNM. We have a long-held shared goal of safe women's healthcare. We have a promotion, both of us promote evidence-based practice, and we're each experts in our fields, and we collaborate based on the needs of the patients. This is important, and I'll talk more in a minute about this, but the seamless quality of care is provided when the system fosters collaboration. So one other document that I think you should have on your bookshelf would be this collaboration and proactive implementing team-based care. This was published by ACOG in 2016, and it was developed by a multidisciplinary task force. There were midwives on the task force, nurses, and other types of providers. And it really does lay out a blueprint for team-based care. Team-based care, by definition, at least two healthcare providers who work collaboratively with patients and their families to accomplish shared goals within and across settings to achieve coordinated, high-quality care. And the guiding principles of team-based care, patient and families are central and engaged. The team has a shared vision, role clarity. What each person does on the team is essential, and all team members are accountable to themselves and to the team. Effective communication is critical, and team leadership is situational and dynamic. Now, of course, this theme of effective communication comes across in every interaction that we have, and is particularly important when you start talking about collaborative care. Without it, we can make missteps, and missteps can lead to mistakes, and those mistakes literally could be disastrous for women. So learning how to communicate with each other is a critical component of collaborative care. And leadership is situational dynamic. So this means that in some cases, it'll be the nurse midwife who is the leader. In some cases, it'll be the obstetrician. If a nurse midwife is working in a birthing center or a midwifery-led unit with a low-risk woman, and she may be the leader of that care. If it's a high-risk situation, then the physician may be leader of the care. So it's situational depending on where you are, what's going on, and it can change. So you may start out with a leader that is a nurse midwife and move to a leader who is an obstetrician, or you may have a leader that is a diabetic nurse educator in any certain situation. So just think about what the patient needs. So back in 2012, ACOG and ACNM leaders got together and they said, I wonder what is going on out there with collaborative practice. What are some of the examples, and how can we get more information? And so they put out a call for papers. So asking different healthcare systems to describe how do they collaborate? What is the collaborative model that they're using? And over 60 papers were submitted. It was almost a competition. Well, it actually was. And 4 of those papers were chosen to be published in Obstetrics and Gynecology. And of those, and the winners and the papers that were published received a stipend. But there still is a tremendous amount of information within those 60 papers about collaborative care. And so an analysis of 12 articles was undertaken by these authors, Melissa Avery, Owen Montgomery, describing the recurrent common themes of successful collaborative practices. So I'm going to tell you what was seen in these 12 papers. There were 5 themes, and I'm going to give you some details on them. So these are emerging themes of a successful collaborative practice. So first, there was a motivation to collaborate in the first place. Sometimes the practice was expanding and they wanted to care for women in a more safe and cost-effective manner. They wanted to be able to provide services that women were requesting, such as more personalized care. They wanted to offer the midwifery model care for women who were requesting a less interventive birth, a more physiologic birth experience. And they wanted to, there was examples of wanting to increase care to the underserved populations. The next theme were basic foundations. So what are the basic foundations of working together collaboratively? Reciprocal consultation, so midwives consulting with physicians, physicians consulting with midwives, collaborating in the care of specific clients, of course, and then specific defined processes for referral of care from one clinician to another. So sitting down ahead of time, laying this out, defining the process, how is it going to happen, so that everybody knows what the expectations are. Methods of fostering clear communication. So sometimes it is practicing how do you have those difficult conversations, or where are you going to have those conversations, whether it's morning huddle, but when is it going to occur so that the communication is clear. Addressing any medical legal issues. So if anybody on the team is concerned about medical legal issues, this issue needs to be discussed and talked about. And evidence-based practice, which is this is a way of ensuring consistent management. So if everybody is practicing based on the evidence and there is agreement on how to practice, and that agreement is based on evidence-based care, it can be very helpful in describing the practice. And that's what we're talking about next in the practice guidelines, both midwifery practice guidelines, but also common practice guidelines. So when you're working collaboratively with obstetricians and nurse midwives, you may develop specific guidelines. So what are we going to do with premature rupture of membranes? What are we going to do with a 36-weeker? What are we going to do? You know, so that there are some guidelines already developed, so everything doesn't walk in the door. You don't start a whole conversation about how to handle it. We need to address financial structures to avoid competition. If there's competition for finances, it can set you up for failure with collaborative practice. So if anybody is benefiting more than another person, well, you just need to work that out. What's going on? Why is it happening? And how can a fair system be developed that serves women well? And last is regulation. Regulation needs to allow full scope of midwifery care. And so this is at the state level, of course, but also within the institution, that there are not limits put on the scope of practice for nurse midwives and midwives, certified midwives, because that can be problematic and limit the care. So the third theme was mutual respect and trust. This is a recurring theme. It doesn't happen by magic. It takes time. It takes working together to create this, but it is imperative. A culture that emphasizes teamwork. So this idea that we are all in this together. Full participation by all clinicians in quality initiatives, credentialing, and other committees. So when you're setting up the organization and administration of the healthcare for maternity care, everybody should be at the table and have a voice at the table, that there's opportunities for leadership for all. And this is critical to have a clear process for resolving any misunderstandings. If there are misunderstandings, what are you going to do to resolve them? A plan up front for when that happens is critical. Next theme is care integration. So this is a shift to a common philosophy of care and committed teamwork with the woman at the center. So the woman is at the center of all decisions that are made about her health care. And the care is based on the woman's health status and her care needs. Separate midwifery and obstetric caseloads are not always necessary. So sometimes you will have the midwife seeing low risk, the obstetrician seeing high risk, but a lot of times there are reports of clinics where the high risk patients are seen by the obstetrician, the midwife is there and also sees the high risk client. Because sometimes when a woman is sick, everybody gets so wrapped up in the illness, they forget that, yes, she's still going to have a labor, she's going to have a newborn, she's going to have a postpartum period, and how is she able to prepare for those things? Another thing is practice guidelines is addressing specific care situations rather than specific providers, which I've already talked about. The last theme was health professions education. And so this is, these practices reported there was inherent value in interprofessional education. There were situations where the nurse midwives were teaching the residents low risk birth. There were situations where the residents were teaching midwifery students. And they found that an interprofessional workplace and clinical training environment has been integral to a sustained cohesion, viability, and productivity of collaborative practice. And so we know that when we educate nurse midwives and obstetricians together, that they're more likely to want to engage in collaborative practice later on and to understand each other's role in the collaborative practice. So there's many models of collaborative practice, probably as many as you can count. There's independent CNM practice. practices with an identified collaborating physician. There's CNM practices working with OBGY residency programs. There's mixed physician and CNM practices. There's hospitals that hire CNMs, laborists, and OB triage staff. So this from Joni Slager talked about her service at Bronson's Women's Service, where she was the leader for more than 25 years. And this is an important component. So when you have an experienced physician working with an experienced midwife, then things are all okay. Both know they're confident in their care and they can collaborate and talk with each other. And when you put an inexperienced midwife with an experienced physician, once again, this can work out. The physician can assist an inexperienced midwife and teach, and that can work out very well. When you have an inexperienced physician with an experienced midwife, also you can have a very good outcome with the experienced midwife having confidence and being able to collaborate with the inexperienced physician. But at Bronson, what they've tried to do is avoid putting inexperienced physicians with inexperienced midwives on the floor together without some guidance. And this can be problematic. What you're trying to do here is improve communication, trust, and experience in collaboration. And it does take some experience to get to that point. So a couple of examples here. I just wanted out of Harvard, I saw this very nice article called Making Room at the Table for Obstetrics, Midwifery, and a Culture of Normalcy Within Maternity Care. And in this article, it says, we advocate for the explicit establishment of professional standards for team-based physician-midwife care. And more than merely introducing midwives into a physician-dominated setting, this means elevating the contributions of midwives and meaningfully incorporating a culture of normalcy to standardized practices such as intermittent auscultation, continuous birth support, non-pharmacological pain management, and positional flexibility in labor. And striking a balance between the cultures and contributions of midwifery and obstetrics is imperative to improving the quality of midwifery care. This was one collab practice that's been in place for many years. Well, actually, it's been in place for many years, but they did a very big focus on collaborative practice in the last 5 years. And this is the Vidal Birth Center at Yale New Haven Hospital. They have 4.5 FT obstetricians and 5.2 midwifery positions that cover the floor 24/7. And then they have outpatient prenatal care provided by Nurse-Midwives at 5 different external sites. They annually attend 1,000 births, 12,000 prenatal visits, and about 2,500 triage visits. They're very proud of the focus on shared decision-making with the mother. They have reintroduced intermittent auscultation, nitrous oxide, water immersion, and a doula program. And this collaborative practice has been able to decrease the total cesarean rate from 30.2% to 21.7%, and the primary rate from 16.7% to 13.1%. They've also increased their volume because when you implement a practice like this, many women who are really seeking a more non-interventive or physiologic birth will come to this practice. And so they, in 2014, had 980 births, and in 2017, they had 1,129 births. So the bottom line here is that together we can do so much. And we know that the ideal situation occurs when midwives, obstetricians, nurses, and other healthcare providers work together in collaborative teams. And we know that the families and women that we serve, they have many needs that cannot be often met by one provider. I hope that you can use some of the concepts in this presentation and share them both within your midwifery community and your obstetric community and within your teams, and potentially even share some of the work that ACOG and ACNM has done together. A quote from the 2012 article, "The truth is that midwives and obstetricians together offer the best of what maternity care has to offer. When the best of both professions are brought together in a successful collaboration, women and their families benefit." And I hope that we can all remember that And I wish you the best, and I hope you enjoy your week this week. And I hope you're able to get back here and listen to the many other presentations that are going to be done and that are coming up this week. So thank you very much. I appreciate your attention, and write to me anytime on email, stone@frontier.edu, if you want to make comments or have any questions. Thank you so much.